Okay, John, we'll get started.
All right.
Okay, everybody. It's a pleasure to introduce our ICCM Grand Round speaker this morning, John Masronarde. He's a leader in the field of asthma and critical care and sleep medicine. He did his BS in chemistry at John Carroll University and his MD at Ohio State. He also did a residency in internal medicine and pediatrics, and pulmonary and critical care and sleep medicine, and as a Master of Science in clinical research. At Ohio State University, he was the director of the Pulmonary and Critical Care Fellowship Training Program for many years, and the Pulmonary Allergy Critical Care Sleep Division's Clinical Trial Office. At University of Iowa, he's director of the Sleep Disorders Center and professor of medicine at Oregon Health and Science University. He's the associate director. He was the associate director of OHSU Sleep Medicine Fellowship. And he's board certified in medicine, pediatrics, pulmonary, critical care, and sleep medicine. And he's involved in all the major pulmonary organizations, ATS, CHEST, the Association of Pulmonary and Critical Care Medicine Program Directors, where I have the honor of serving with him on the board writing committee. And at ATS, he's currently involved in a diversity and awards initiative, and he's on the awards committee. He's a reviewer for many journals. He's on the editorial board of Mayo Clinic Proceedings. He's on the Drug Safety Monitoring Board for studies, including improving asthma control using internet-based cognitive behavioral treatment for insomnia, one of the latest ones. And I could go on and on for the whole talk here today, talking about his achievements in the field of asthma and pulmonary. And today it's really a pleasure to have him speak on sleep in the ICU. It's something that doesn't always get a lot of attention. And despite the fact that there are studies in sleep in the ICU, relative to other fields, there really isn't that much in that area. It's wide open, I think, for continued research. And we all know how important sleep is in the ICU for our patients in the ICU, as well as for ourselves. So without further ado, pleasure to introduce Dr. Masronarde, who will talk about sleep in the ICU.
All right. Good morning. Thank you, John, for that generous introduction. And you said currently I'm at the Portland VA and OHSU Health Sciences University, mainly pulmonary critical care, and I'm kind of doing more sleep at this point in my life. And sleep in the ICU is something that I've had an interest in for quite a while. And so today we'll kind of talk about a few things. Let's see. There we go. I have to use my mouse. For those of you who haven't been to the beautiful Pacific Northwest, this is our medical campus. So I live over here. Hopefully you can see the mouse pointer. That's the VA facing Mount Hood. If you notice this side, all of the patients have basically floor-length windows, so they get a great view of the downtown and the mountain. And then we have a long suspended walkway over to OHSU and the Children's Hospital, etc. So if nothing else, it's a pretty place to watch sunrises and sunsets on your nights on call or when you're working in the hospital. So today, since many of you probably have not gotten a lot of sleep or heard about sleep since medical school, hopefully you've got some talks there. That still remains a challenge. We'll talk a little bit about normal sleep, and then I'll kind of go over what we do know. And John alluded to, there are some things that we do, and quite frankly, a lot that we don't know about sleep in ICU patients in terms of quality of sleep. What are barriers? What kind of interventions can we do to improve it? And does it make a difference in terms of outcomes? And then at the end, something that I think is a little more concrete, we'll talk about sleep apnea in the ICU. So sleep has derived from several different languages, which you can read there. In mythology, Hypnos, who's the guy on the left here with the wings, that's his twin brother Thanatos, who is death on the right. It explains why in a lot of classic literature, sleep is often linked to death, and there are various quotes that go with that because they are twin brothers, at least in the mythology. The Merriam-Webster definition of sleep talks about naturally reversible period of many living things, marked, of course, by absence of wakefulness and loss of consciousness, typical body posturing, talks a little bit about dreams and activities, and then usually considered essential to the restoration and recovery of vital bodily and mental functions. I highlighted usually considered because despite the fact that we spend a third of our lives asleep, we still don't know why we sleep. There are a lot of postulates, there are a lot of theories right now. There's a lot of focus on sleep being potentially a period where your brain clears itself of toxins and regenerates. But bottom line is we still just don't know why and the exact functions of sleep, which I think is still pretty amazing and interesting. So sleep is a relatively young field. This highlights some of the main landmarks in sleep medicine. EEGs, Zazarinsky and Kleitman describing REM in the 50s, and then sleep stage scoring, which has undergone several revisions since then. 1970 is kind of considered the benchmark of when sleep medicine began, mainly because Bill Dement, who's pictured here, was a psychiatrist at Stanford and started the very first sleep medicine clinic, along with Dr. Christian Gilmano, who was a neurologist that worked with him. Dr. Dement unfortunately died this year, but is considered the father of sleep medicine and was really one of the early proponents of sleep as an important field, but only in 1970. So really still a relatively young discipline. In terms of normal sleep, so these are EEG tracing. So wake, you can see alpha waves, so pretty fast, kind of things are a little chaotic. Non-REM sleep consists of stage N1, N2, N3. Most of our sleep is spent in N2 and N3. So N1, when you're staging sleep, so looking at sleep studies, it really becomes pattern reading. You can kind of see this is pretty fast and then it slows down. And so that's kind of when you start dropping into sleep. In stage 2, you have these little sleep spindles, which are episodic, very fast waveforms, and then big, huge K complexes that are pretty easy to spot. And tell you you're in sleep 2, stage 2. Stage 3 is more slow, big delta waves. And then REM is nothing really in particular on the EEG, and in a lot of patients looks a lot like wake, which we'll see is kind of a common theme. REM is the most active and is a pretty active stage of sleep. And typically you cycle from non-REM to REM every 90 minutes or so. And this is a sleep hypnogram that kind of shows the sleep stages in the night in a normal adult. You can see you're awake here. It's never as nice as this, but ideally you drop into N1 sleep, then N2, then down to N3, come back up, and then you have periods of REM. Your REM sleep in a normal adult gets longer as the night goes on. And it, again, kind of cycles 90 to 120 minutes or so. In contrast to that, I think everyone can relate to this. This was a hypnogram put out there kind of in an article talking about residents and neurology-based trainees and sleep fragmentation, which will be important when we talk about ICU patients. But again, another normal sleep hypnogram showing the periodicity and increasing REM. But then here they've labeled these things as pagers. These are people, you know, trying to go to sleep and then they get aroused and wake up. And this is happening over and over, as opposed to the nice smooth thing. You get kind of all these jagged episodes. Here they're starting to have a nice dream and boom, they wake up again, and it continues. So in the ICU patients, you could take away these pagers and put in noise or vital sign checks or doing a blood draw. So the point is, when we talk about sleep fragmentation, this is what we're talking about. Episodes of repeated arousals and awakenings that are much different than our normal, nice, smooth night of sleep. Lots of things change when you go to sleep. So some of the physiology changes, things tend to slow down your rate, we'll talk about some of the other breathing issues in a second here. Again, REM is a little more active, so things are a little more variable. Temperature, your body works pretty hard to keep a normal temperature when we're awake. It's a little lower in non-REM. And then one of my favorite sleep words, when you're in REM, you become poikilothermic. So your body temperature is regulated to your environment. Why you wake up early in the morning if you've left the window open and all of a sudden you're freezing cold because your body's kind of adjusting to your environment. And then an important thing to remember when we talk about ICU patients or certain chronic lung disease patients is that in REM, we are essentially have atonia, so your skeletal muscles are paralyzed. The only thing that works in terms of respiratory system is your diaphragm. So in someone who has, say, severe COPD, who depends on their accessory muscles and who may have diaphragmatic dysfunction, when they hit REM, they're really susceptible to having desaturations or decreased respiration. And on sleep studies, what we'll see is, or even on a pulse ox, you'll see the oxygenation maybe dropping a little bit, and then there's these profound drops that can happen in REM. When we think about our ICU patients, particularly with the interest in diaphragmatic dysfunction, say after a ventilator, or a COPD patient has been on a ventilator, then you may see some of that, and these things persist. Say you send this person to the ward, there may be big drops in their oxygenation that, without understanding, is this normal? Is this part of REM, part of their sleep, may be mistaken for something else going on. But that is a significant issue that when you pay attention to, particularly in COPD, you'll see it quite a bit. Manifests itself quite a bit anyways. So there are other breathing changes, and I won't go through all of these, but the respiratory center lives in the pontine medullary regions, and that all kind of decreases in its firing for various respiratory control at nighttime. And again, overall, you can see things starting to decrease, minute ventilation, respiratory rate, with REM being a little more verbal. You don't respond or wake up to the same levels of hypoxemia or hypercapnia as you do when you're awake, particularly in REM. And then in terms of sleep apnea, upper muscle tone and upper airway resistance become more problematic for those folks, again, mainly in REM versus non-REM. So for people who have disease patterns, REM can be a dangerous period in terms of the respiration, but it's thought to be very important in terms of cognition and being alert. So it can be kind of a double-edged sword, if you will. So the classic postcard picture of downtown Portland, Mount Hood looking over. This is essentially the view from the VA a little bit over to the right, not from my office, which has no windows, but from a lot of the patient rooms, which looks great. So chosen to kind of frame a lot of what we know about ICU and sleep from the SECM guideline in 2018, which I think did a great job in raising this issue and kind of putting together some questions about what we do and what we don't know. Not a lot has really changed since then. So this is kind of what I'm going to focus a lot on for this part of it. So in 2018, they added immobility and sleep disruption to this guideline and the pain, agitation, and delirium as compared to 2013. They again had 37 recommendations, which we're all used to. Only 2 of them are rated strong because there isn't a lot of great quality evidence for a lot of these things. They did use grade methodology, which kind of accepted standard. And then interestingly, and I think importantly, they put ICU survivors on the committee this time to give a patient's perspective, which in some of the things we'll talk about, I think is really important as we consider some of the issues that sleep in the ICU. So they did both descriptive questions and intervention framed in PICO. So description just kind of, what is sleep quality, for example, which we'll go over and you'll see, but just putting out what we know, and then more PICO for more of the interventions. Again, you can read about the methodologies if you care to, but they followed kind of the grade guidelines for panel, narrowing, putting some topics out there, generating some questions, literature review, and then voting on what should be the main points. That's kind of the cutoff. You can see the topics here, right at 4.3 is a little break point. So things that did and didn't make the cut this time for them to discuss. And in terms of their, oops, sorry about that. in the descriptive questions. So the ones that I'll talk a little bit about are how is sleep in critical ill patients different from healthy sleep? We just went over that. The summary cut to the chase is sleep time and sleep efficiency are often normal, but there's a lot more fragmentation. We'll talk a little bit more about that. Delirium, essentially to say whether delirium affects sleep is very unclear. Same thing is true. Does sleep affect delirium? Not exactly very clear in terms of the ICU. We'll touch on this a little bit, but the delirium sleep is a very hot topic of research, but without a lot of clear cause and effect yet. Clearly a lot of associations, but nothing quite there. We'll talk a little bit about mechanical ventilation, which interestingly has gotten a lot of research on looking at factors in sleep or certain modes or certain types of ventilation better for you to sleep, and then kind of outcomes. Won't really talk too much about different patterns of sleep. And then they mention the different types of risk factors here. Commonly, or common sense tells you if someone's got chronic insomnia or has poor sleep at baseline, they're going to persist, and maybe that's going to be even worse when they come in the ICU. Similarly, if they've got some mental health issues, anxiety disorders, that could worsen their sleep in the ICU. So it's important to know that as a baseline for the patient. And then what are ICU type factors that affect people's sleep? And then again, does sleep or the lack thereof have consequences in terms of clinical outcomes? So we'll talk about some of these a little more in depth that have some data. So sleep architecture in the ICU. Interestingly, total sleep time over 24 hours is normal. However, the quality of the sleep isn't very good. And in particular, a lot of that sleep happens in the daytime, anywhere from 30 to 60%. So one way to think about this is over 24 hours, you sleep the same amount of time, but you have multiple short periods of bad sleep that persist throughout the daytime. Most of it is stage 1 and 2. Again, no slow wave or REM sleep, which may be important for some physiology functions. Not surprisingly, patients say their sleep is worse than the ICU than it is at home. Importantly, again, as I talked a little bit about, this may persist for several days if you transfer this person out of the ICU. So when people are coming back or bouncing back, or you're getting called, hey, this guy doesn't look so good, some of this could be related to their sleep, and it's important to figure out what's going on, particularly if you're getting called at nighttime. Now, the one caveat that will serve the theme for basically most of what we know about sleep in the ICU is none of this data is great. It's all from very small studies, lots of variability in the metrics, how they measured sleep, how they defined sleep, a lot of single center studies in different populations or mixed populations of patients. So part of the, qualifying statements or conditional recommendations in the SCCM document is because the data and the evidence base here is just not great, which for those looking for ways to find a niche in critical care in their career, there's a lot of room to do a lot of research in this area. But we certainly need a lot better data. So we'll talk about the data we have, but even all of this, which we know, quote unquote, about sleep, is really got some not a great database to support it. So environmental factors that come from the ICU that can result in sleep deprivation or poor sleep. So noise, I think, has probably gotten a lot of publicity. Lighting practices, which are kind of both too much and too little. So too much light at nighttime, not dimming them, or too low of light in the daytime, so the person isn't stimulated to really think they're awake. Patient care, nursing vital signs, blood draws, etc., procedures, of course, medicine, sedatives, analgesics, and then things that happen from the patient if they're having some delirium / psychosis, pain, a lot of stress. All of these things can affect the patient's sleep. What do patients commonly bring up as the most common barriers to their sleep? It's noise, being woken up, stress, being scared, and then pain, lack of pain control. And I think this is what has fueled a lot of the interventional protocols or bundles to try and affect these factors that are commonly noted by patients and may be modifiable. So noise is a big one. It was always a big one for me. Drives me crazy when the ICU is so loud and you can barely hear somebody presenting or the patients or the families. We know that noise pollution is associated with physiologic disturbances when measured in normal people. The WHO has recommendations for hospital noise, saying it should be less than 35 decibels in the daytime and less than 30 at night, with peaks of less than 40. For reference, a normal bedroom at nighttime is about 20 or 30. So give you a little allowance for some noise. ICU measurements are from 50 to 65. There are apps on your iPhone where you can measure decibels, so you can figure out how loud your ICU is at different times. Peak noise has been measured anywhere from 70 to 95, which for reference, a gas lawnmower is about 90. So a lot of times somebody's firing up a lawnmower right in the middle of your ICU in terms of noise and factors there. This is common noted by patients, but it's reported in a lot of the surveys. But again, when you start to look at the variability, when people measure, so do PSGs or some derivative and actually measure sleep, noise or noise disruptions in those studies, admittedly small, have been 15 to 20% of the arousals, which could be a big percentage. Again, if you go back to all of the different factors, we don't know what amount of the arousals are from light or from patient or nursing interventions or other interventions. But to me, when I saw that, it was like, that's kind of small. I would have expected it more to be like 50 or 60. It kind of reverts or highlights the issue that is also another theme when you're starting to look at these protocols or sleep promoting procedures, is that it really varies per individual. And a lot of the studies have lacked to account for individual patient preferences. So some people just clearly aren't distressed by noise. That doesn't arouse them. They don't wake up. One thought is that maybe the noise becomes just kind of a cacophony of sound that everything just blends in. And after a few days, that becomes the baseline, if you will. The ICU becomes a sound machine for people to go to sleep with lots of white noises. And so they just aren't disrupted by fluctuations above and beyond. Could be sedation, lots of other factors here. But it to me reinforces the point of, it's not always as easy or as it would seem that, boy, the noise is a big factor, we should make it quiet. Maybe, it's certainly 20% is nothing to sneeze at, but it's not 80%. And it doesn't affect every patient the same way. So we've talked about a lot of factors that can affect sleep. And so so what question, why should I care? What does it matter? Does it do anything for people? Well, sleep deprivation, we have a fair amount of data, not in the ICU, but we know in animal models, can't really do this past most IRBs, totally depriving people of sleep, because in the animal models, the rats die if you deprive them. In human studies, you can do short-term deprivation, and there are clear alterations in mood, problem with vigilance, decreased performance of tasks. We've all experienced this post-call. For those of us of a certain age, you knew your big wisdom from your resident was make no decisions post-call in your life as an intern, because the world will look much different the next day. In the early days, it was a thought that sleep deprivation in healthy people would cause them to be psychotic and have long-term effects. We're talking about the 1960s. This is a link, but if you look this up in a BBC feature on the boy who stayed awake, the 17-year-old kid who decided to break the Guinness Book of World Records for staying awake. Bill Dement actually went and participated as a monitor, mainly to help the parents' fears. So he stayed awake for 11 days. He did not go crazy. Got a little loopy at the end, got really tired. They struggled to keep him awake. I've heard Dr. Dement talk on this. And then at the end, once he broke the record, he was just fine, went to sleep, had a huge REM rebound in his first night, and then got up and went to school the next day, which advantages of being 17. But this at the time was pretty concerning, because people really did think that sleep deprivation would cause some long-term damage to you. So in the ICU, again, I alluded to this, and we'll have a little bit more notions on that, but Associations with delirium and sleep deprivation and poor sleep are out there. Really observational data, various populations, no real cause and effect, but lots of smoke, if you will, around this fire. This seems to be something that people believe is true, and trying to figure this out is, I think, a focus of a lot of folks right now. There are, again, as I mentioned, surprisingly to me anyways, a lot of associations on sleep and mechanical ventilation in terms of modes and which one helps you sleep better. Uh, some of the data looking at, do night sleep predict weaning? Can you measure night sleep and predict who is going to get reintubated after extubation? Some positive signals there, but again, observational values, different populations, pretty small studies. So something to think about, but certainly nothing to be definitive about. So like most things, and is noted in the SCCM document, need a lot more data. You can imagine how tough it is to do these studies though. I mean, first you got to measure sleep, which right now is very difficult in the ICU. And then you have all of the confounders. And again, most of these studies have not controlled very well for the populations, or have controlled too well in their single center, single ICUs. So this is an area that I think is going to continue to get a lot of study, but it's a pretty tough area to totally, and I'm not sure we're ever going to know definitively, cleanly, high quality evidence for sleep. But it's also an area of how much do you really need to? Is this kind of the, is a parachute a good thing when you jump out of a plane principle? It can't really be good for you not to sleep. I mean, I think we all know that intrinsically. There doesn't seem to be an argument that poor sleep or sleep fragmentation is a good adaptation in a critically ill patient. So I think despite a lack of high quality firm evidence, people have found this important and are promoting ways to improve this. This kind of postulates some of the ways that this could be a bad thing. If you look at sleep-wake dysfunction, sleep deprivation, things we've talked about, hospital, pre-existing issues, acute morbidities, there is some data to support all of these. Again, nothing 100% firm to lay my professional reputation on the line, but there are some data to support sleep deprivation causing issues with insulin resistance, of course, mood instability, neurocognitive, we talked about a lot of interest there. Inflammatory response, the issue of sleep deprivation and including sleep apnea and the immune response has gotten a lot of studies and a lot of data. Clearly something is happening. I don't know that it's very consensus into what. Endothelial dysfunction, again, to try and explain, or as a postulate for a lot of the cardiac issues along with oxidative stress in patients. So all of this has some data to support it as an association or a consequence of sleep-wake dysfunction and sleep deprivation, which of course translates to potentially increased length of stay, decreased patient satisfaction, which is bad for all of us. And then morbidity and mortality. There are lots of community studies for a long time now that show sleep deprivation is associated with increased all-cause mortality, in particular in cardiovascular mortality. So not a big stretch to think this could be an important cofactor in the ICU patient's outcomes. But again, no direct definitive data, but it seems to be this is an important area. And so can you improve patient sleep in the ICU? Portland, we have the world's smallest city park. This is Mill End Park, right in the middle of downtown. There's the Willamette. A variety of things are planted there, but it always kind of cracks me up every time I drive by that little park. So can we change this? Can we improve people? So there are some of the PICO questions that they put out there with their different approvals or their recommendations. Again, you can see all conditional, some nones. We won't talk about all of these. We'll talk about some of them. Right now, they don't really recommend monitoring sleep. I think there's still just a lot of limitations. Hopefully, as technology is rapidly progressing, we'll have better, good ways to measure sleep. And by good ways, I mean really measuring sleep, either brain waves or a technology that is pretty clearly associated with sleep and sleep staging in critically ill patients. For those of us in sleep, I can't tell you how many of my patients are coming in now because their Fitbit has told them they have sleep apnea or they're desatting, which in some cases is good, in some cases not so much. But I think the technology is hopefully progressing that this will be something that will have a little more reliable mechanisms for. Again, using assist control at night, we'll talk a little bit more about what's conditionally recommended. No recommendations on mode so much. Again, you should use either a ventilator or a BiPAP machine for non-invasive ventilation. They passed on aromatherapy or acupuncture or music as individual interventions. They do recommend noise and light. Again, all of these are conditional. I'm not going to talk about the drugs. Suffice it to say, there's just not a lot of good data here. There's some data for some of the medications, but propofol and benzodiazepines, for example, will put people to sleep. They'll suppress REM. So is that a good thing or a bad thing? There was some recent interest because of dexmedetomidate showing some improvements, but again, limited data, variable patients, pretty expensive. Melatonin is given a lot. There are continued small single site centers. So there's some signal there, but right now, there really is nothing definitive to recommend a drug at nighttime to help an ICU patient go to sleep for the most part. I would say if they're taking something at home, that might be something to consider. So they do also recommend using a multi-component protocol. It's interesting that they split out noise and light, and then also multi-component noise and light are almost always in those as well. So we'll talk a little bit about those. I just find it interesting, the assist control ventilation at night data and this recommendation. So this is, I'm sure like a lot of you, something I was always taught. Someone's on pressure support, they're not extubating. Well, let's put them back on the vent to let them rest overnight. And this is, I think, what generated a lot of these studies. First thing, of course, you notice is it's pretty small. So not a whole lot of patients, 61. This is mean difference in sleep efficiency. So leaving them on pressure support versus putting them on assist control overnight. Positive study, again, in very limited numbers of studies in patients. Similar thing for REM, that's even less. So yeah, there's something here, but boy, not anything that's really definitive. And their rationale for why they would put this recommendation out is that while the quality of the data is low, given the potential benefits, the fact that it's low risk and that all ventilators have assist control modes, a conditional recommendation was made. I find this very interesting, and I think it's great that they threw this out there. For me, not so much for the, boy, everyone should go on assist control at night, but I think everyone should be thought about for this. So to me, this raises, again, awareness of, so you have this patient, what should we be doing about their sleep at night? This is a person on pressure support. Are they going to get a benefit by assist control, or are they going to get worse? Because those people will point out in some of the discussions and editorials about this, if you put someone on assist control, they hyperventilate, they blow their CO2 down, they have central apnea as they wake up. If they air trap and set off the alarms, they wake up. So in the individual patient, this may not be a good therapy, but I think it raises the bar in terms of what are we going to do for this patient at nighttime? What in this particular patient can we do to help them sleep better? Should we put them on a vent overnight? Should we leave them on pressure support? Should we do something else? So in my opinion, that's what's important about this recommendation, not so much that it's put everyone in assist control to help them go to sleep. And so the other ones are really the interventions, which I think probably have in your ICUs or have had in your ICUs, and what's the data for those. So this was a meta-analysis done by Sai Parthaswamy's group at the Arizona, which has a big research and sleep institute. And so it was pretty exclusive. They only looked at randomized controlled trials, objective measures of sleep, so no questionnaires, and then looked at interventions and mechanical ventilation, again, as we talked about, pharmacologic and non-pharmacologic, so things like music, those kind of things, lights. And they showed that in all of the interventions, you can increase sleep efficiency, you drop that sleep fragmentation, but the effect was pretty small. Again, lots of issues with the data being heterogeneous, and the clinical significance is unknown. But when you look at the best quote unquote data we have, it does seem to indicate, and this is a theme through all of this, you can get some benefit. Is it dramatic? It depends on where it is, but almost all of them show that we can get some improvement in sleep efficiency. This is from the SCCM document that just kind of goes over from supplement the studies that had a multi-component protocol in the ICU. Only really want to show this to again highlight some of the what has been tried and some of the issues. So here, earplugs and eye masks that we talked about before are pretty common, very small groups. Perceived sleep. So a big deal is how do you measure sleep? This is a common questionnaire filled out either by the patient or in the ICU. If the person's delirious or unable, the nurse typically fills it out. Again, that's a measure of perceived sleep. Can't really say that's sleep, but that's one of the limitations in a lot of the studies. And you can see the interventions, mainly daytime interventions, which is going to mean lighting and noise, opening the shades, closing the shades at night. This study kind of had a multi-tiered approach, adding drugs at the end. And here is where you see some of the variability in the delirium. A lot of these studies did use the CAM. This is a little bit bigger. So here, no improvement in perceived sleep, but delirium went down. Low uptake of some interventions, earplugs and eye shades, which again, to me was interesting, and where some of the patient input came more to help clarifying this, because you would think, well, if noise and light are such a big deal, gosh, it would be great to give everyone eye shades and earplugs. Why would people turn that down? Well, the patient perspective in some cases is, I'm critically ill, I'm in a little bit of pain, I'm scared out of my mind, and you want me to be blindfolded and put earplugs in so I have no idea what's happening or who's around me? Yeah, no thanks. So I think, again, that emphasizes for an individual patient, all of these interventions or some of these interventions need to be considered whether they're going to be a positive or a negative. For some people, maybe that's a good thing, but for others, it might just freak them out more. In the VA population, the PTSD folks who suffer from PTSD, this is going to be a non-starter. They're not going to want to do that. And so again, here's some more observational data, very small, very small. You see no decrease in delirium for eye shades plus earphones. Here, adding a few more practices or a few more interventions in a med-surg ICU, you get a decrease in delirium. So the delirium signal is all over the place a little bit, but I think it's an important one and one of the main focuses to see if we can have an effect, because it kind of makes sense teleologically that if you can improve people's sleep, you should or may be able to improve their mental status or their consciousness. And again, their rationale for the recommendation based on the low quality data was potential for benefit, minimal harm. But they do bring up an interesting point that in some cases, sustaining this, both implementing it and keeping it going, can be resource intensive. So it depends on your protocol. In some of these cases, that needs to be factored in, which I don't think is discussed in a lot of these studies. So sleep almost made the SCCM choosing widely last list for critical care, which is done by consensus and then voting and review of what they're going to put out there. So there was a pretty good uptake of people who thought that, minimizing disruptions at night was a good point. Finished number 7, they picked 5, so it got pretty close. So I think the word is getting out there and people are thinking about that, which is a good thing. And I just put this one in. There's several other smaller studies that have come out since the guideline. This one just was published a couple months ago, maybe even in September in Chest, that I wanted to highlight, not so much because of the quality of the data, because again, it's perceived sleep, and they had a multi-system intervention in a SICU that was gen surge, trauma, and cardiac, and found improvement in the CAM, which again, we've seen before. But I thought it was nice in terms of how these studies hopefully are getting more focused. In this case, they had their intervention and they used a check sheet. Well, of check sheets these days, and it shows you what percentage they achieved of the different metrics. Now, some of them, it's not clear exactly what unnecessary alarms prevented, but shows that at least in terms of focusing on it, getting people to look at it, a lot of these things are pretty high level achievements or a high level of achievement, 70, 90%. The earplugs and eye mask, again, now probably not surprising, pretty low, but for some people, obviously were a good thing. And then things that seem pretty straightforward, dimming the lights, efforts to decrease noise, were pretty high uptake. They did have a fair amount of drugs, particularly melatonin, that seems to be used pretty commonly here in some patients. So to me, it was just kind of interesting in that they had an approach to try and standardize their intervention, making sure it worked. None of this looks like it's going to be really resource heavy to me, and showing that, again, you can have some impact, or at least you can do these things in the ICU. So kind of for that part of the things, we know that sleep quality, or we think we know based on what we have right now, is impaired in the ICU. It appears we can improve that. Interventions can be done at the entire unit and then also at an individual level. And I think it's important to keep those two things separate in your mind. Clinical outcomes are a bit unclear, going to be hard to get robust data, but boy, it'd be great to have it. In particular, multi-center data on specific populations with measurements of sleep that's more than questionnaires, and technology may kind of help with that coming down. And then I think hopefully as these studies move forward, there needs to be more assessment or discussion about impact on staff, not only in resources, but in one paper, they talked about the well-being or how the nursing or the night shift was improved with some of these measures because it was a more calming environment, wasn't as chaotic, which I think is another interesting angle that we all realize is important in terms of burnout and those things in the ICU. So Portland likes to be weird. This is our Unipiper. It's now become a spokesperson, does PSAs for vaccines and other things, rides around his unicycle and his kilt with his bagpipes. He'll shovel snow as well. So he's kind of entertaining guy. So I showed this before in terms of the PICO question prioritization. One of them, which didn't make the cut and was quite a bit off of the 4.3, was sleep disorder breathing in the ICU. Distressing to me because I think in some of the things that made the cut, this one could have been a little bit higher, and hopefully I can impress upon you why I think that's true in terms of what we can and can't do for people with sleep issues in the ICU. So we've all seen a similar patient to this 60-year-old person, elevated BMI, comes in with both hypercapnic and hypoxemic respiratory failure, baseline 60-60 club kind of guy, afebrile, it's got a lot of pedal edema, irregular pulse, probably AFib, has some PFTs that reflect his obesity, chest x-ray, nothing too exciting. And so likely diagnosis on this patient in an ICU, you can all pause and think in your mind a little bit about what you would be looking for exploring them. Probably a similar thing. So COPD would certainly come to mind here. And then hopefully sleep apnea, obesity, hypoventilation syndrome, or a combination of the above. Unfortunately, these are not that often considered in these folks, at least in the data we have on this topic. Merrick's group did a couple of different studies, both retrospective of people admitted to the ICU with hypercapnic respiratory failure, trying to look at how many people really had obesity hypoventilation syndrome diagnosed from a chart definition retrospectively, so obviously limited. But they found that 75% of people they felt met the criteria for OHS really were diagnosed as the cause of their hospitalization as COPD or asthma. He then did a subsequent study in all hospitalized patients over 5 years and found still a pretty high percentage of people who were either misdiagnosed or in my mind, really a diagnosis of OHS was not made. They could have COPD or asthma, but there was some suggestion that this person had obesity hypoventilation, and that was missed, I think is a more accurate way I would look at that data. A prospective study in 2017 looked at everyone admitted to an ICU with hypercapnic respiratory failure, so a little more specific group of 78 people. 37 of them agreed to do a sleep study within 3 months. So people who survived 3 months discharge. 66% of the people with COPD had sleep apnea. 94% of the people without COPD had sleep apnea, both indicating sleep apnea is either a good significant comorbidity or a cause of or contributing cause of hypercapnic respiratory failure. The people who refused or did not get a PSG had an increased risk of readmissions or mortality at 3 months. Similarly, there was a smaller study done, same type of setup, hypercapnic respiratory failure, 35 patients, 16 agreed to do a PSG, and everybody had sleep apnea that was pretty severe at 15. This was just published as a letter in the annals that I actually really liked. So this group looked at people admitted to the ICU over a 3-year period for hypercapnic respiratory failure without a known diagnosis of sleep apnea or obesity hypoventilation. And for those who survived, they administered a stop-bang questionnaire, which we'll show in a bit, on hospital discharge. And people who were high risk, which is greater than 3, were offered a portable study within 3 weeks. You can see the demographics here. Most people were obese, kind of a good split of men and women, fair amount of COPD. Some of them did have known obesity hypoventilation, which would have been thrown out of the study. But of the people with acute respiratory failure on their chart here, you can see there's 417. So they threw out people who did not have, who had hypoxemic respiratory failure primarily. So you had to be hypercapnic. 250, 50 of those people did not make it. So of the survivors, there were 198. And when they gave them the stop bang, 83% of them were high risk. And so of those, some of them were lost to follow-up. Small number said they didn't want the sleep study. So 124 of the 164 did do a sleep study, and 104 of those, or 84% of them, were positive, kind of consistent with a high stop bang. But to me, 53% of all of these patients had undiagnosed obstructive sleep apnea that was picked up after ICU discharge. I think that's pretty significant and clearly something that's pretty easy and not resource intensive to think about or consider doing. And in terms of some of the other data on sleep in the ICU, there is a lot of data that, while is not potentially firm cause and effect, is pretty commonly accepted that sleep apnea can make everything worse in multiple situations. So post-stroke, post-OR complications, more emergent ICU or RT calls. Cardiology is very invested in that sleep apnea makes AFib harder to control, can be a cause of AFib or contributing cause, post-MI, et cetera. Question recently, does it increase your risk for AKI if you're critically ill? Obviously, there's some suggestions these days that it makes your COVID outcomes potentially worse. And again, there are a lot of confounders in this data that makes it not entirely clean, because a lot of these folks are obese, and there's some suggestions that the more obese you are with sleep apnea, the worse. But there is a lot of data, I think, and it's pretty hard to say that having sleep apnea doesn't make a lot of issues worse in the ICU. Offering rationale as to why should you care, what can you do about it. This kind of postulates and puts together some of the things that we know about sleep apnea. So for fellows, this will show up on your boards probably. Obstructive apnea, so you see thoracic and belly movement with no flow, desaturations, arousals. Kind of, I'm not going to read all of these things, but what's the most important? Hypoxemia, fragmentation, or intrathoracic pressure swings. Each probably has a role, and together are postulated to be not so good for people. With some of the endpoints, none of them firm, but I think it does a nice job of putting out there why we should worry about sleep apnea from a mechanistic standpoint of disease. This is a study that's quoted a lot in COPD patients, showing both survival and exacerbation-free survival. These are folks who have COPD and sleep apnea, and when you treat them with CPAP, they do pretty much the same as if they did not have sleep apnea. For the people who have the overlap syndrome not treated with CPAP, they do much worse. So they have worse survival, worse exacerbations during the time. So again, in that population with COPD, making a diagnosis and finding a way to treat that person could potentially be pretty important. So again, for me, this study, why I liked it was pretty focused. Hypercapnic respiratory failure comes in the ICU, screen them for sleep apnea if they survive. I don't think that's very intensive and big payoff. About half of those people, if your population is similar to this one, may or may not have sleep apnea that you can intervene on. The questionnaires that are used in most of these, so the stop bang and the Berlin. Stop bang primarily started with anesthesia and screening and perioperative settings. The Berlin was more in primary care. Again, these are made to be pretty sensitive, and the stop bang is very sensitive, but not too bad specificity as well. This is a stop bang in the VA population. There's good data that the stop is just as good. The bang, everyone is positive in this VA. So we tend to just look at the stop, and 2 or more is considered high. And there's the Berlin, a few more questions, just different variations on the same theme, but pretty easy to do, pretty easy to put in an EMR to check off. So in conclusion, the things we talked about already is that sleep quality is impaired in the ICU. I think we should, and what the SECM, I believe, was raising is that sleep should be considered a part of the care plan for ICU patients. Maybe it deserves its own checkbox on a checklist for each person. I think interventions can be done at the unit level. Clearly, we can improve some sleep quality. I think a lot of it depends on what does your unit need. How are these interventions structured? It's still unclear about clinical outcomes, but as we talked about, that's hard data to get. Hopefully we'll get some more robust data coming up. Clearly, always sleep apnea or obesity hypoventilation is underdiagnosed in ICU patients, which can have important outcomes. Increase in recognition is needed. There's pretty clear therapies and ways to diagnose this. And I think overall for trainees or junior faculty, sleep is a pretty young discipline. A lot of questions to be answered, a lot of areas in ICU and ICU research where patients in the field could benefit from some additional studies. Sleep fellowship is 1 year. We can train people from a variety of disciplines, internal medicine, so critical care, pulmonary critical care. One of my colleagues is a hospitalist. Family medicine, psych, neuro, we have an anesthesia, sleep boarded faculty. There's only, I believe she said 24 or 30 of them in the country. I've yet to see anyone in ENT go through sleep, but they do a lot of sleep as well. But it's certainly something to consider, and I think could be an interesting career for someone. So that's the end, and I think right on time. There may be some time for questions. I'm happy to stay as if there are issues or discuss anything. So thank you.
Dr. Masronarde, John, I want to thank you for a really insightful and clinically informed review of sleep in the ICU. You touched on a lot of really important points. I was, I did know one ENT physician that did sleep. He had a practice when I did sleep for a year around 2006. And he was one of the preceptors who went to his office. But,
yeah, nice. Do most of the ICUs in Sinai have a sleep protocol or sleep intervention?
We have things like quiet time, lights off at night. We've done decibel, measurements and trying to reduce the sound levels. And we had that before COVID. We're doing that. We still have things like quiet time and try to reduce interventions at night.
May I ask a question? So many patients in intensive care are given propofol for prolonged periods of time, which is probably contributing to some of the neuropathy that they or muscle dysfunction they have. Are all these factors even alterable by since we use propofol so much? So I'm wondering, what are the effects of propofol for prolonged periods on the alteration in sleep architecture and duration?
Sure. So what is known is that it will increase Sleep efficiency. So people obviously are sedated, so they're not going to arouse as much. Whether that makes a difference using that hasn't been shown. But again, it does decrease the amount of REM sleep. So you do get a little trade-off. So you get better consolidative sleep, but REM sleep is felt to be pretty important, REM and delta sleep. So propofol kind of increases your N2, I believe, in most of the studies. So that may be some of the issue, but I don't think you can really make a firm statement either way. Is it good or bad? It's not good enough to do on every patient. I think that's a fair statement. If that's the only reason you're putting someone on propofol to help them go to sleep at night, boy, that's a pretty hard argument to back up with any data, and probably not something that should be standard.
Another issue is when I was studying negative pressure ventilation in normal subjects, because we wanted to see how we could, how they behaved in an iron lung, in fact. We found that when we achieved what I call respiratory satiety, namely they were comfortable with what the iron lung was doing to their breathing, they all fell asleep. These are normal subjects. So I wondered whether this mode could be another way of using to help better sleep in the intensive care unit when patients are less critical and don't have to have as intensive monitoring or as many lines in place as a weaning strategy. I'm just curious what your thoughts would be.
I think that's really interesting. I would say that we know that negative pressure non-invasive or iron lungs make sleep apnea worse. And in some neuromuscular kids, muscular dystrophy, have a high proportion of sleep apnea, it can make it worse. So it's interesting that to put them to sleep, I think you just have to monitor those things very carefully. And maybe in a person at high risk for apnea, who's going to be tough to fit in an iron lung anyways, typically at their level of obesity, that might be something to think about. But it can change the upper airway caliber and pressures, and has been known to worsen sleep disorder breathing. So it's an interesting question as to why they fell asleep, though. They obviously liked it.
Yeah, they were very comfortable. That was that was interesting. So that's why I was curious. I'm aware of the upper airway problems with that. And the fatter the patient is, the more muscle dysfunction they have, the higher the risk of that occurring, because the muscles are already not functioning well. And of course, the diaphragm in those patients are often not functioning at all. So clearly, REM sleep is a big risk for them in any setting except for invasive ventilation. But you can do non-invasive for these patients in the daytime and use other positive pressure systems at night, not necessarily invasive at night. But most patients hate endotracheal tubes and hate a lot of invasive lines. So I wonder, when in your patients who are serving as helpers, how much a sense of loss of control led to inability or fear to fall asleep.
Sure. I mean, that was noted quite a bit. I think in any of the studies, they talk about ICU survivors, that fear, panic, stress, that is all part of it. And again, played into why some people don't want to be blindfolded in the ICU or have earplugs in. They're scared. And so they don't want to be in the dark, so to speak, of who's in the room and what's going to happen next. So yeah, you're absolutely right. That's an important factor.
Dr. Masronarde, thank you very much. And we have actually another meeting coming on.
Okay.
And it's really been a pleasure. Hope to have you back again. And,
thanks very much for the invitation.
You're welcome. Take care.
All right. Everyone have a good day.